Welcome to AETCM Emergency Medicine channel. So I am presenting about a case, a 72-year-old male patient coming from Palluruthi, Edakochi, and he was a conductor on a private bus. He has a background illness of HIV infection for the past 16 years, and he was on antiretroviral therapy with tababacavir, lamivudine, and dolutegravir. And he has also a known case of type 2 diabetes mellitus and systemic hypertension. So presenting complaints was he had pain while passing urine for the last 3 days and increased the frequency of urination for 1 week and passage of clouds in urine for 2 days and weight loss of around 15 kg in last 6 months and loss of appetite for 8 months, reduced food intake for 8 months. So coming to the history of presenting illness, patient came with complaints of increased frequency of urination for past 1 week and pain while passing urine for the last 3 days. Patient also noticed a passage of small red-colored clouds through the urine, followed by relief of pain after passage of clouds. Urine was dark yellowish colored, and there was frothing of urine. There was no history of lower abdominal pain or loin pain, fever, chills, constipation, or loose stools, or vomiting, or blood in stools. Patient also gave history of loss of appetite for the past 8 months and reduced food intake for the past 8 months. Patient also gave history of weight loss of around 15 kg, that is from 55 kg to 40 kg in the last 6 months. As patient had pain while passing urine, he was taken to ER for further evaluation and management. Past history, known case of HIV infection and type 2 diabetes mellitus and systemic hypertension. Personal history, he was having
When you're taking HIV history, what all things you have to ask?
Whether the patient has any active infection, any features of active infection, fever, weight loss,
Then
diarrhea,
okay,
and cough with sputum and breathlessness.
you have to ideally ask what is the last CD4 count. That is very important because the difference between a normal person and HIV person is a CD4 count. If CD4 count is low, then you can suspect a lot of other infections other than a regular infection.
Yes.
CD4 count is good in HIV patient. It is as good as a normal person. So no need to worry about HIV at all. So first of all, you should know what is a CD4 count, and later you should know about previous opportunistic infection, other complication he had, all these things, and whether he is taking tablets regularly or not. So if he is missing, what is the problem? Suppose he is missing tablets frequently, then what happens?
Treatment failure and resistance to the
it will become a resistance case.
Yes. So coming to the personal history, mixed diet, appetite was reduced and bowel habits was unaltered and bladder habits increased frequency of urination and no involuntary passage of urine and passage of blood clots in urine. And he has quit smoking around 15 years ago.
At this age, HIV patient clots in the urine, what will you suspect?
Urinary tract infection.
It is not.
And
that is a primitive answer.
Kaposi sarcoma in
one is TB, another malignancy. So these are two things you should suspect. Okay, urinary tract infection, normally it will not produce clots. It can produce clots in severe bleeding and all, but that is rare. But genitourinary tract tuberculosis or cystic malignancies in the bladder, these are the two things you should suspect. Okay, it can be simple UTI like you told, but first suspicion should be always like this.
And he has quit alcohol intake around 15 years ago. And family history, his wife had HIV infection for the past 15 years and she had died last year at home. And then no history of malignancy in family, no history of HIV infection in daughters.
Daughters?
Daughter. He had one daughter and one son.
So you feel that it will spread like that?
So perinatal transmission can be there from mother to child.
At that age, maybe. What is the age of the daughter?
Around age of the daughter around 30s to 40s. And coming to the general examination, patient was conscious, oriented in time, place and person, and he was alert and cooperative. and he was severely emaciated with loss of body fat. And
What is Slimming disease? Yesterday I asked you. Slimming disease.
so in HIV in patients there can be severe wasting associated with a less than loss of weight more than 10% body weight within the last 1 year, associated with prolonged diarrhea, chronic diarrhea for more than.
Nothing will be there. Only weight loss will be there. That is Slimming disease. There will not be any diarrhea. Patient will lose weight. So one of the cause for that it is tuberculosis. Okay. Without tuberculosis also they can have same problem, but the common problem in that type of patients will be tuberculosis, and you may not get any clinical evidence of tuberculosis because their immunity is very low.
So this patient was severely emaciated with loss of body fat and prominence of the ribs, and pallor was present. No icterus, cyanosis, clubbing, or pedal edema.
What is the reason for pallor in HIV patient?
So there can be bone marrow suppression, and anemia of chronic disease can be there.
Anemia of chronic illness is the most common thing. Then bone marrow suppression is due to?
Sir, HIV itself can cause bone marrow suppression.
Yes.
And antiretroviral drugs like
Old drugs can produce. No, new drugs will not produce. Any virus?
Sir, parvovirus.
Parvovirus. That is the most important cause for bone marrow suppression in HIV. Parvovirus.
Yes. And bilateral cervical lymph nodes were enlarged in cervical area, and 0.5 into 0.5 centimeter.
You have to tell me what is the type of lymph nodes, matted or discrete or tender?
Non-tender, non-matted, not fixed to skin.
Okay.
Pulse rate was 80 per minute, normal rhythm.
What is the size of the lymph node?
0.5 into 0.5 centimeter.
Okay. Is it significant in HIV patient? Lymphadenopathy in HIV patient?
So in HIV patients there can be generalized lymphadenopathy.
Generalized lymphadenopathy is known.
Yes.
In all these patients. What is generalized lymphadenopathy by definition?
More than one group of lymph node involvement, enlarged lymph node involvement.
Okay, more than 0.5 centimeters in more than 2 groups.
More than
3 months, then it will become persistent generalized lymphadenopathy. These are the typical features of HIV. That's why I'm asking.
So pulse rate was 80 per minute, normal rhythm character, and atherosclerotic vessel wall. No radioradial or radiofemoral delay.
What is the BP?
BP was 110/70 millimeters of mercury in left upper arm in sitting position. And respiratory rate of 20 per minute, abdominothoracic. And temperature was 98 degree Fahrenheit and saturation of 99% in room air. So coming to the systemic examination, oral cavity examination, his lips was dry with cracks and poor oral hygiene, with a loss of molar teeth in upper and lower jaws, and Malden teeth with chalky white deposit at the base, and tongue was red moist tongue with loss of papillae, with smooth appearance, and white patchy deposits was there.
You think that it is candidiasis?
Yes, oral thrush.
Oral thrush.
Yes. Coming to GET examination, in inspection, abdomen was mildly distended with bilateral flank fullness. Umbilicus was everted and flushed with skin, and hypopigmented patch over umbilicus and right upper quadrant of the abdomen was present, and few dilated veins were present over the abdomen, and normal abdominal wall movements with respiration.
What should be the position of patient to comment on the veins in the abdomen?
Patient should be in a supine position with
standing. To comment, you need to have standing position. Patient need to have blood vessels. Blood vessels can be there when you are lying down, but you have to see whether it's a persistent, problematic, dilated. Then you have to make the patient stand up. Okay. It's all basics of examination. That's why I'm telling.
And normal abdominal wall movements with respiration and no visible peristalsis or pulsations. A swelling of 7 into 7 centimeter was felt over the right inguinal area, and scrotum of penis was normal. So coming to the palpation.
The swelling is what type of swelling it is? Lymphadenopathy? Inguinal area?
Inguinal area.
Hernia?
It's a hernia, inguinal hernia. Reducible hernia. So palpation, lower border of the liver was palpated 5 centimeter below the right costal margin in the midclavicular line, firm in consistency, and surface appeared irregular and no tenderness. Spleen was not palpable, and abdomen was having a diffuse firm consistency, and right inguinal swelling of 7.7 centimeter with cuff impulse palpated, which is reducible with no tenderness and smooth surface and firm consistency. Percussion, a liver dullness noted over the fifth intercostal space in mid-clavicular line, in the seventh intercostal space in the mid-axillary line, and liver dullness extends down to lower border found around 5 centimeter below the right costal margin at mid-clavicular line. And liver span was calculated at 16 centimeter, and no shifting dullness or fluid through was present. So auscultation, normal bowel sounds were heard, and external genital examination, scrotum appeared normal with no swelling, and penis there was no local lesions or phimosis or epispadias. A right inguinal hernia with cuff impulse was present. Per rectal examination, no rectal mass was palpated, and the prostate appears firm in consistency, non-tender. And respiratory system examination, normal vesicular breath sounds, urinary bilaterally equal and no added sounds. And so CVS examination S1 S2 was heard, no murmur, and CNS examination E4 V5 M6 and no focal neurological deficits.
Okay. So what investigations are done?
Sir, we have done
What is your clinical diagnosis?
So this patient hematuria was there. It can be due to tuberculosis, as sir has already said, and it can. We have to also suspect CMV infection causing hemorrhagic cystitis, and other urinary tract infection causing hematuria, and malignancy has also should be ruled out. So we have done routine evaluation and.
So what is the test you have done for CMV infection in this patient?
So CMV DNA levels has to be checked, and ophthalmologic evaluation has to be done to rule out. Yes.
Okay.
There was no CMV retinitis features, and UST abdomen was also done, and it was showing right HUN and left hydronephrosis with the left kidney was shrunken in size with the loss of CMD, and bilateral and a bladder wall irregularities was there with a bladder wall thickening of 7 millimeter, and prostate was also enlarged, and there was diffuse.
What is the size of prostate?
32 cc.
30 is the normal. 32 is not that, but slightly enlarged.
And diffuse omental wall thickening for around width of 5 centimeter was there, and they suggested cross-sectional imaging to rule out peritoneal or other malignancies.
Okay.
And liver showed nodular surface irregularities with dilated CBD with mild ISBRD.
Okay. So what is your suspicion now?
Sir, since the patient was having diffuse omental thickening, we had to rule out peritoneal involvement.
Peritoneal involvement of what?
Malignancy.
And
tuberculosis.
TB is the first thing to rule out. Malignancy is second. Okay. TB is the most important because he's a retrovirus patient, low CD4. What is the CD4 count? CD4 count has come 81. So it is low. 81 is the CD4 count. So what do you think? 81 is the count. Is it normal or abnormal?
No, it is very much reduced.
Very much reduced. What is the normal CD4 count?
Usually 2500, more than 2500.
2500 we rarely see. Maybe 1200 to 2500 is a normal range. When it is low, less than what level, what are levels you can see in patients? Like it can be for less than 500, less than 300, less than 250, less than 50. What is the importance of all these things?
So less than 250 we have to suspect coccidioidomycosis, and less than 200 PCP pneumonia, pneumocystis infection we have to rule out, and less than 150 histoplasmosis has to be ruled out, and less than 100 both toxoplasmosis and cryptococcus infection.
Here it is 81. 81.
And less than 50 Mycobacterium avium complex and a CMV infection has to be ruled out.
Mycobacterium avium complex, this can be Mycobacterium avium complex also. But what is a typical feature of Mycobacterium avium complex? How do they present? Mycobacterium is TB. What we are routinely learning is TB. You are telling about tuberculosis of the omentum, the first diagnosis. If the CD4 count is very low, it can even Mycobacterium avium complex. What is
It
that?
can also present a pulmonary involvement.
What type of pulmonary involvement? What is the involvement of pulmonary involvement of Mycobacterium avium? That can be bilateral infiltration and mediastinal nodes are common presentations. Mediastinal nodes are actually common than infiltrates, but it will be definitely like other tuberculosis also. Okay, so Mycobacterium avium complex is one possibility. Mycobacterium tuberculosis is common thing what we are seeing. Okay, now you are talking about CD. We are talking about CD4 count, no? When you are starting the treatment, this patient may be on ART. When you are starting the treatment, how the CD4 increases, and when you are not treating the patient, how it decreases. What is the range you can observe in patients? How it increases, how it decreases.
Usually, when we start antiretroviral therapy, the CD4 count can improve by 100 per year.
100 per year. Like drop also nearly 100 per year. So suppose you see a patient today with 1000 CD4 count, if you don't treat next year, it can maximum go down by 900 or 800. And even if it's like now, if we start properly in this patient treating, next year it may become from 81 to 200 or 250. That's all. It will not increase, like it will not jump from 81 to 500. Okay. So that is one of the problem we are going to face in this type of patients.
Yes, sir.
Now, what other problems are there? Omental thickening, tuberculosis, one possibility here. What else is there? What are the other things you have observed in this patient? Bladder, what you have seen?
Bladder wall thickening was there.
Okay, so how do you make how can you make a diagnosis from that bladder wall thickening?
So we have to do urine routine examination and gene export, urine gene export we can send.
Okay, that is negative, no? That is negative. So what is the next option? So gene expert is negative. So what is the next option?
Urine culture can also be sent
Urine
for
culture can be done.
tuberculosis.
Okay, then
And we can
once gene expert is done, normally we may not get it because gene expert is highly sensitive. Okay, but you have to send it. What else? Cystoscopy.
cross-sectional. Yes, cystoscopy and biopsy we can
Biopsy
consider.
is the most important. Now, if you want to make a diagnosis, you need to have a biopsy report, either from omentum or bladder, whatever it is. You have to do one. Easiest is from bladder. Cystoscopy and biopsy can be done. But the only thing is physical condition does not fit for all these things.
Yes.
He's emaciated.
Yes.
Okay. Now, so that suppose you make a diagnosis of tuberculosis now, how do you go ahead with your treatment?
So if the patient is having an active infection, first we have
It's an active infection, no? So suppose I take a biopsy and see that it's a granulomatous tissue and suspicion of tuberculosis will be high.
Yes. Then we have to start ATT.
Oh.
And usually with ART we have to stop if you are starting ATT.
You have to stop.
To rule if the patient can develop iris. So that.
What is iris?
So
Iris. Iris is what? Iris.
So immune reconstitution, inflammatory response.
Immune response, inflammatory. Immune reconstitution, inflammatory
response.
Okay. So that happens when.
So if the patient is having an active infection and we are starting ATT, then the patient can develop.
A patient is not having HIV infection, not on ART, and he develops tuberculosis or any other opportunistic infection.
And
we start ART first, antiretroviral therapy first. Then he develops good immunity and develops reaction against current infection. But it is not like that. This patient is already on ART. Maybe he is not taking properly or something, we don't know. And now he has come with suspected tuberculosis. And biopsy, like suppose it is positive for tuberculosis, you have to treat tuberculosis now. Okay, you cannot think about iris. Iris is a separate scenario where you are starting ART first, not ATT. So here you can start ATT. Anti-tubercular drug can be started. Okay. Now, what are the combinations you routinely use in ART therapy? You were telling something.
So
Recent guidelines only you tell.
yeah, the most preferred
So
one
you
is,
have a patient, you are seeing first time a patient with HIV infection in your OPD. Okay. How do you treat the
so
patient?
the most preferred
You are
latest
seeing the
regimen.
patient now.
Yes.
His HIV positivity is shown in the ELISA test. What do you do?
So ELISA is a screening test. We have to confirm it with Western blot.
Is it right? What is the current guidelines? Emergency medicine, it is not required. That's why I'm not asking you. What is the current guidelines on ELISA test of HIV?
So it is.
Western blot is required?
So it is sensitive,
Huh?
but
Western blot is not required. Western blot was a previous generation test, and currently we have fourth generation or fifth generation ELISA that is as good or better than Western blot. So nowadays, no need to do any Western blot test. You are getting one ELISA positive. If you have doubt, one more ELISA test you can do. That's all. There is no need to do Western blot, or you go for higher test like PCR test, HIV, RNA PCR. In RNA PCR, there are two types of PCR. So, what are the two types of PCR? So, you do HIV ELISA, that is positive. You want to do the PCR, a patient want to confirm it. So, you are going to send RNA PCR. In RNA PCR, there are two types of tests. What are the two types of tests? HIV, RNA, there are two types of tests. What are the two types? Quantitative and qualitative. Qualitative means you want to make a diagnosis. You just send qualitative. That will tell whether it is positive or negative. Quantitative means you want to count the viral load. That is called as viral load. So that will tell you that 1000 copies per liter, 10,000 copies, or 1 lakh copies. Okay, 1 lakh copies are very high numbers. Okay. CD4 count, again, you will ask for CD4 count, baseline CD4 count. But will you wait for CD4 count or viral load to start the therapy?
no, irrespective of the CD4 count, whenever a patient is presenting with a diagnosis, then we have to start in all patients.
Previously it was less than 200, then it has become 300, then it has become 500. Now you are not going to see the CD4 count at all. You are going to start the ART first itself. So once you diagnose HIV ELISA positive, if you want one more test you can do, or PCR you can do, start the therapy. What are the preferred drugs nowadays?
So preferred is TLD regimen containing tenofovir, amivudine, and dolutegravir.
These are the preferred drug regime nowadays. Okay, so that you can start. When will you check the CD4 count?
Usually after 3 months of therapy we have to.
CD4 count or something else?
CD4 count.
CD4 count we have already discussed it. It increases only by 1 year 100. We know that. So in between no need to check it. What is the test you do after 3 months?
So viral load can.
Viral load. Viral load should be done after 3 months. And what should be the viral load?
So suppression of the viral.
It is undetectable, less than 20 copies. Undetectable means we are not seeing, but it is there in the body. So that level you have to reduce. If it is not coming down, then you have to suspect a resistant strain. Okay. So the CD4 count is not a good investigation the first 3 months. You can go for viral load. If viral load is suppressed, then your treatment is good. Okay. Patient has to take the tablet daily. Okay. Suppose you get a needle prick from that patient, what will you do? You are getting a needle prick. This is a common problem. Most of the doctors should know. So we are going to treat the patient. Patient will definitely improve. If there is no other issue, patient will definitely improve. You cannot make out the patient whether he is HIV positive or not. But if we get a needle prick, what to be done?
So ideally, if you are getting a needle prick injury from a HIV patient, we have to start post-exposure prophylaxis. Ideally within 1 to 2 hours, and it can be taken up to 1.5 days. So post-exposure prophylaxis.
Plan. You are getting a needle prick today. What do you do? So you have to do the test first. Suppose I am getting a needle prick, I have to make sure that I am not positive now, because we are working in a hospital. There is a high possibility we are already positive, then we will miss it. Okay. So you are doing a ELISA test first. Then you have to start the same regime. What you have explained: dolutegravir, tenofovir, and emtricitabine. That can be started. How long you continue that? So 1 month, 28 days or 30 days you can continue. Then what you do?
Then we can recheck.
What you will recheck? What you do? P24 and old. When we were MBBS students, we used to live. That is there in our current ELISA test. That in that panel you see, no, it will be P24, ELISA, everything will be written. That panel it is there. Some hospital they may not do. P24 is a good test, but nobody does that now. What is the current guideline? PCR you have to do. So after
RNA
2 weeks, if you are infected with HIV virus, you can get PCR positive. So you go for RNA PCR. Okay. So after 2 months, you can go for RNA PCR. You can even still you can do the ELISA test. That also can be sometimes positive, but RNA is the best investigation. After 6 months, again you do one more test, then you can stop it. There is no point in doing repeatedly. Okay. But all these patients, including healthcare professionals, should be given proper counseling.
Yes.
That is very important because we'll have a lot of doubts, including doctors. We'll have a lot of doubts regarding the infectivity, how it will get infected, which are the modes which can spread HIV faster. You get a lot of different types of injuries: scalpel injury, suturing injury, blunt needle injury, bore needle injury.
Needle stick injuries.
Needle stick injury only one. Suturing needle, wide bore needle. So many things are there. What is the risk? How much is the risk for a bore needle injury?
3%.
3%. I think it is 0.03%. Out of 1,000 patients, you may get 3% can get infected. Okay. The two wide bore needles are more dangerous. Suppose you get a needle prick which is thrown out. The needle is already thrown out 1 hour back. That is HIV patient. You get a needle prick injury. Will it be infective? So you are putting an IV line for HIV patient. You kept it there. After 1 hour, a nurse is taking that, and she is getting injury from that.
It can be infective.
These are the common problems we will face in the hospital. Will it be infective? It is not infective. 3 minutes only, 3 to 5 minutes, it can survive outside body. That is the advantage of HIV. Okay, whereas hepatitis B, that survives more time, more than HIV. Okay, so that is more dangerous than HIV. HIV, once the virus come out from the body, within 3-4 minutes till die. It cannot survive outside human body. So that is an advantage. Okay. So even then, when you are treating a HIV patient, we have to take all precautions. Okay, that is a must. Okay. Now what happened to the patient? Finally, what is the diagnosis now we are making? We are only treating for urinary tract infection. AFB is negative, gene expert is negative. Now you have to rule out, either you have to take a biopsy and see what it is. Otherwise, you have to what is it? You have to open the abdomen and see what laparotomy has to be done. Otherwise, we will not get any diagnosis. But these patients normally very difficult to survive because he may not be taking the drug properly. He might have developed drug resistance HIV. Then the treatment options are very limited. So a lot of difficulties will be there. Even if this is tuberculosis, then also it will be difficult because he may not tolerate all the anti-tubercular drugs. So there is a difficulty in that type of patients. Anything else? Okay. Thank you.